Assalamu alaikum. My name is Dr. Bushra Essen. I'm one of the hematology consultants here in Shaukat Khanum Memorial Cancer Hospital and Research Center. I would like to invite you to our second hematology session for today. We have four guest speakers, and it's a privilege to have them for this session. It's Dr. Kamran Rashid, who's a consultant oncologist in Shifa International Hospital. He will be our first speaker. After that, we have Dr. Shahrukh Hashmi, who was with us in the first session as well. Then we'll have Dr. Usman Sheikh, and last but not the least, Dr. Sue Wimong. So first of all, I'll invite Dr. Kamran Rashid, consultant oncologist from Shifa International Hospital, to start his talk on updates in the management of Hodgkin's lymphoma. Dr. Kamran, will you unmute yourself and share your slides? Thank you.
Can you hear me?
Yes, we can.
Okay, great. So I'm going to talk about some updates on Hodgkin's lymphoma. I have a lot of slides, but I will try to just focus on the practice-changing data which has come out, and I'll be very quick in what I will do. So I'll start with the early stage Hodgkin's lymphoma, then I'll move on to the bulky, then stage 3 and 4, and then in the relapse setting, what's really going on. So this is actually the high-risk categorization for different types of societies for early-stage Hodgkin lymphoma. I'm going to present an EORTC H10 study. This study actually divided these patients into high-risk and low-risk based on their criteria. And basically, the question was whether we can omit the radiotherapy and we can just give them chemotherapy. The top bar shows the favorable early-stage Hodgkin lymphoma, and the one at the bottom is the unfavorable Hodgkin lymphoma. And the gist of the study was the arm which had the favorable the top line is the PET positive or negative, and at the bottom the question was if they become PET negative, omitting RT is better or just giving them chemotherapy is better. So what this study showed was that in the favorable category, you need to give them involved nodal radiation because of the difference of 5-year PFS of 11.9%. Whereas in the unfavorable group, the arm which got 4 more cycles of ABD was pretty much the same. And the overall survival for this, both the favorable and unfavorable, was unchanged. Similarly, for the patient who have PET positive disease, there is an advantage of giving them BioCop escalated with INRT rather than just giving them chemotherapy. And this is the conclusion that the 5-year PFS for the PET positive disease, 77.4% versus 90.6%. And there's an overall survival also difference between arm getting just ABVD of 89.3% versus 96%. This has led to a CLGB Alliance trial, which will ask the similar question in a prospective fashion. Now, how about the bulky disease? This is the HD0607 trial, Italian study just recently published. This is the study design that the patient were 320 patients assigned to PET in the end of the treatment if they're PET negative. One arm got no further treatment, the other arm got radiotherapy. And you can see this is 5 to 7 centimeter, 7 to 10 centimeter, more than 10 centimeter, and you can see there's pretty much no difference. So if they're PET negative at the end of the study, the PFS and overall survival advantage is not there. And I believe this study has pretty much settled this question in our clinics, whether to radiate them or not to radiate them. Now move on to the stage 3 and 4 disease, Hodgkin lymphoma. This is the famous Ashkelon study published in New England Medicine in 2018. This is brentuximab vedotin, which is the CD30 antibody attached with the linker, methansine. And what this study question asked was taking out bleomycin and adding brentuximab vedotin in ABVD arm. Is it better than just simple plain ABVD? The primary endpoint was PFS. And what this study showed was the overall, the arm which got BV-ABD, 82.1% 2-year modified PFS versus the arm getting ABVD with a PFS of 77.2%. And these are the graphs. And what the study showed was that there is 33% fewer subsequent chemotherapies in the arm getting BV-AVD, and there are 33% fewer high-dose chemotherapy in the arm getting BV-AD. And these are the side effect profile. There was higher neutropenia. Febrile neutropenia was almost double in the arm compared to ABVD. So this is what they published, that if you want to give BV-AVD, you need to add GCSF to these patients. Otherwise, the treatment will be delayed and the benefit of this drug will be lost. Similarly, a lot of 20 to 30% of these patients will relapse. They will have refractory and relapse disease. And standard of care is offering them autologous stem cell transplant. It's usually done in stem cell chemosensitive disease. You need to collect stem cell adequate organ functions and 70 years of age or younger. That's our cutoff. And also in the salvage setting, a lot of people are using brentuximab vedotin combinations with chemotherapy. A very popular combination is NLKC, very high CR rates of 74%, response rates of in the 90%. And this is the Athera trial. How about offering these patients brentuximab vedotin in the maintenance setting? The primary endpoint was PFS, and the second endpoint overall survival. And this drug was given for a total of 16 cycles. And this is the survival difference. The arm getting BV is 42.9 months versus 24.1 months. And there is no difference in overall survival. These are the 5 risk groups which really benefited. So if you have refractory disease less than 12 months, or you are a primary refractory, best response to treatment is PR or stable disease, you have B symptom, more than 2 prior salvage tendency, or you have external disease. These are the patients who really benefit from this maintenance treatment. So if you have 2 risk factors, the hazard ratio is 0.4. If you have more than 3 risk factors, the hazard ratio is 0.3. So what are the emerging things? There is recently some data which I'll show showing non-chemotherapy salvage regimens, and then offering them pembro as consolidation post-transplant. Just like I showed you the data of brentuximab vedotin, you can offer pembro as consolidation. And similarly, combining pembro and nivolumab as consolidation post-auto. So these are all the questions which have to be answered. This is actually a study published in Blood 2019, in which pembro as a maintenance was given after transplant. And what they showed in the study was that the PFS went up from 60% to 80%. And this strategy has been moved on to a phase 3 study. But this is actually a CheckMate study. This is a non-chemotherapy salvage regimen, CheckMate 744. This is induction chemo with nivolumab and brentuximab vedotin for 4 cycles. If you go into complete metabolic response, you are moved on to transplant. Versus if you are in partial or non-metabolic response, you get bendamustine added to your brentuximab vedotin for 4 cycles. And what these are the patient dispositions. This was just recently presented in ASCO 2020. And what you can see is there's the 93% of the patients who got the combination had greater than 50% reduction in SUV max, and they're the complete metabolic rate of 88%, which is very, very high. And these are the patient safety signals. You can see that the grade 3-4 toxicity was very minimal in the arm getting 4 cycles of brentuximab vedotin and nivolumab. So the overall response rate of 98%, it gives us an option without chemotherapy, and nivolumab, brentuximab can be given as a salvage chemotherapy. Further follow-up will be needed. Now, this is another practice-changing study, the Keynote 204 study design. This is a phase 3 open-label study in the patients who were ineligible for transplant or who relapsed after transplant. So a lot of these patients don't get brentuximab vedotin upfront. So the 2 options are available. One is the pembro and other is the brentuximab vedotin. They were compared head-to-head with 35 cycles. And these are the patient characteristics. And the primary endpoint was PFS by a blinded investigator central review. And you can see that the difference between pembro and brentuximab vedotin was 8.2 months for BV arm versus 12.6 months. And it even went up to 19.2 months if you look at the BCIR. So it's a big difference, hazard ratio of 0.65, and all the subgroups benefited from the arms getting pembro. And even if you have gotten brentuximab vedotin in the upfront setting, you still benefit from getting pembrolizumab. And if you did not get it, you still benefited. And these are the overall response rate of 65% versus 54%. There's the estimated difference of 11.3 months. And majority of these patients had partial response. And median duration of response was 20 months versus 13.8 months. These are the side effects. And you can see that with the brentuximab vedotin, you get more of a peripheral neuropathy and sensory neuropathy. And with the pembro, you get hypothyroidism, pyrexia, pruritus. And these are the side effects of pembro, which showing hypothyroidism more of the patient. You can see that most of pembro was very well tolerated. These patients had very minimal itises, which a lot of people are scared to use these drugs. So this was the conclusion. The PFS was 13.2 months versus 8.3 months. Overall response rate was 65.6 months versus 54.2 months. And this most probably has become the new standard of care. So if the patient has relapsed and after auto or is not eligible for auto, and you have to choose between brentuximab vedotin versus pembro, pembro is the drug of choice. Similarly, checkpoint inhibitors of allogeneic stem cell transplant, there's a lot of question. It can cause a lot of more of the GVHD. This is actually a study by Merriman published recently in 2017 in Blood. These are the patient characteristics. It's a lymphoma study, and it included Hodgkin's lymphoma. And the PD-1 inhibitor was given like nivolumab and pembro, and the duration was between 30 to 6 median days were 62. And what they showed was that, this is overall survival, PFS, 1 year cumulative relapse and non-relapse mortality, which is pretty much the same. And there was not much of a difference between acute and chronic GVHD overall, but there were 4 acute GVHD cases, and 3 of them, these patients they died. And the incidence of grade 4 acute GVHD was 14% versus 3 to 4%. And similarly, SOS was slightly higher in the arm which got pembro, that is 8% versus 2.1%. So while, allo can be offered to these patients, but we have to be careful while using these drugs, and these things have to be kept in mind. You have to be on top of GVHD in these patients. Last but not the least, CAR T therapy. CAR T therapy has made a lot of inroads in relapsed lymphoma as well as in ALL, CD19 CARs. But in Hodgkin's lymphoma, this is actually a lot of studies out there. This is one of the studies I picked up, and they used anti-CD30 CAR for relapsed Hodgkin's lymphoma. And what they showed was in this study, there were like 7 prior lines of therapy were given. So most of these patients have gotten auto transplants, allo transplants, immunotherapies, as well as brentuximab vedotin. And what they observed in this study was that there were like cytokine release syndrome was only in 10 patients. It was of grade 1, and the neurological toxicity was not observed. And what they showed was that they used 3 kinds of regimen: Fludara and cyclophosphamide-based regimen, bendamustine-based regimen, and Fludara bendamustine. Majority of this patient got flu-cy regimen with was 72%. And what they showed was the overall survival was 94%, and whereas the PFS was 36%. And these are the final graphs which I'd like to share in the last slide, that the survival was pretty good in these patients. And there was a quick drop off, so giving them a PFS of 36%. And once they divided the arm which did not get fludarabine, that is the only bendamustine arm, you can see that this arm was, the outcome PFS was very dismal compared to the arm which got flu-cy. So most probably for future CAR T regimens, most of them lymphodepletion will be done through a flu-cy arm. So with this, I would like to thank you.
Thank you very much, Dr. Kamran. You wrapped it up quite nicely. In fact, I was worried that the slides would not finish, but you have done it very nicely. Since we have a couple of minutes, I might ask you a question before our next talk. You've mentioned the use of pembrolizumab and in patients who are relapsed post-transplant or those who are ineligible to transplant. In our setting here, because we have limited availability of these drugs, brentuximab and pembrolizumab, we have to get there on patient name basis, which might take long. So in that case, would you use these like pembrolizumab as a bridge to transplant?
Your question is that after autologous stem cell transplant?
No, before you, for example, a patient had 3 or 4 lines of salvages chemotherapy, and they're not eligible for transplant. Or in other words, their disease burden is that they haven't received partial remission or remission to get transplant. And in that case, you cannot get Pembros or brentuximab straight away here in our setting. It might take a couple of months. And if you want to take patient to transplant, you might use that as a bridge rather than just a continuous therapy, because nobody will be able to afford it. Do you do that there in your setting as a bridge to transplant, or use it for 3 months or 4 months? And
what I do is usually my preference in these kind of patients, especially if they're high risk, less than 12 months, or they received multiple lines of treatment, I try to give the analocases regimen, that is the bendamustine and brentuximab and vedotin. Very well tolerated, very good outcome. They have a very high rate. These studies have shown if these patients go into autologous stem cell transplant in CR, their outcome is a lot better if they go in PR or in refractory disease. So my go-to regimen would be a brentuximab and vedotin based regimen in these patients. But as you rightly said, there is issues, cost issue, availability issue. These drugs are not available. So then whatever is available, whatever you have not tried, that can be tried, for these patients. Benda can be tried, bendamustine can be tried. There's some data with lenalidomide also. Benda, lenalidomide, ibrutinib data is also available. There are a lot of options for these patients which can be easily tried.
Okay, I think we have a few more minutes. So let's see, there's a question, I think, from our trainees. And one of them asked, why can't fludarabine-based regimens like FLAG be used in case of relapsed refractory Hodgkin's or non-Hodgkin's or salvage? I think it's one of our trainees have asked this question.
I'm
do you want to answer that?
Somewhere down the line, if you do some research, you'll find some papers in which fludarabine has been tried, because so many effective other drugs are available now with rituximab and with, IOs. So, obviously interest in these old regimen fades away when you have so many newer drugs coming out, and then BiTEs are coming up. Now the CAR T therapies are coming up. So I don't think so anybody will go, you will not see data from the developed world talking about FLAG and all these old drugs. That's one of the reasons.
Another of the fellows has asked, in case BV plus AVG is used and PET scan is positive after 2 cycles, where do we go? Do we go to escalated BIOCOP?
In an early stage Hodgkin's, or you're talking about advanced stage Hodgkin's?
I think the question didn't mention, but probably it's an advanced stage Hodgkin's from the looks of it.
So it's escalate. You do a PET, intense PET. If your PET is positive, you escalate. You go to escalated BIOCOP. The escalated BIOCOP is very difficult. See, even in US, a lot of experts find it very, very difficult to go get your patients going through escalated BIOCOP. But if the PET is positive, that's what NCCN guidelines also say, that you have to escalate your treatment and then do PET at the end of the treatment. Should not go on with ABVD. If the PET is very hot, there's no point of pushing ABVD for. And that's the point of doing interim PET. At that time, you can change your algorithms. If you are positive, you move to escalated. If you are negative, then you're on the right track.
There's another question that if we use checkpoint inhibitor as a bridge to allograft, how long before the allograft would you stop checkpoint inhibitor to avoid GVHD?
In that study I showed you, there was like a 30-day median, but from 30 to 60 days. Now, obviously, there is a concern that if you give them too much time, they may relapse also. So somewhere between 30 and 60 days, depending on the disease, how heavily they're treated, how good their performance status is, But I will wait at least a month before moving on, giving them a month washout period. And keep a very close eye on GVHD, in these patients. That's where you will get hurt with these patients.
Okay. All right. And let's see if we have another question here. Someone asking, what is your experience with single agent bendamustine in case of relapsed refractory Hodgkin's? If yes,
it's
how
very
was
promising. I believe the response rate is very high. Single agent bendamustine responses in the range of 50 to 60%. That's very high. And that's why in the CAR-T study, which I showed you, one or two patients just got benda as a lymphodepleting agent. But the responses, if you look at, I didn't bring those slides up because there is some data on lenalidomide, would have been a long discussion. But the responses were not very long lasting. There's a very quick fall off in these patients. If you look at the curves, that initially they gave some response, but patients very quickly fell off the cliff. Especially this data is from patients who have gotten bendamustine, I'm sure immunotherapy. Some of them have gotten autologous stem cell transplants also. See, one thing I would like to mention is that please keep autologous transplant in your back of your head. We know that it's a highly curable disease. Patients do very well, but still, if 20 to 30% of these patients will relapse. So just don't keep on hitting them with different lines of chemotherapy and not thinking about transplant. If you send them too late to a transplant center, if they get hit too hard, it'll be difficult to mobilize stem cells. Their performance status will go down. The morbidity of the procedure will go up. So it's very, very important to keep this thing in your head that, if they relapse, they need to be evaluated for transplant.
Yes, definitely. I agree with these new immune therapies with the checkpoint inhibitors. You're checking and you're inhibiting immune system at multiple levels, and the more you linger on till the unexpected side effects or GVHDs that are difficult to manage. So thank you very much, Dr. Kamran. That was a pleasure. We'll move on to our next speaker now. Dr. Shaukat Hashmi is our next speaker. He's the chair of hematology and oncology in Sheikh Chakbooth City, Abu Dhabi, and also in Mayo Clinic, US. He has an interesting talk to share with us regarding artificial intelligence in hematological malignancy. Thank you, Dr. Shaukat, once again.
Sure, thank you very much. First thing, can you hear me properly?
Yes, we can. Okay, so you can share the slides.
Okay.
Thanks.
Wonderful, great. Thank you very much. So I'm going to start the share screen, and I'm going to put in the slideshow now, and let me know if that works.
Yes, we can see it.
All right, cool. Thank you. Thanks again for having me. I'm going to talk about some AI basics, AI in hematology, and then bone marrow transplant and the future of AI in hematology. And because it's kind of a new concept, as you mentioned, there are some basics that I would like to go through. And I'm going to start with the basic of computing, which is input and output concept. The 0-1 data and bit concepts, actually, they still apply to the basic computing for the artificial intelligence as well. And that concept, I'm going to show you a little bit more about that. There's a lot of knowledge engineering in this particular field of machine learning. Basically, it would require a huge amount of data. And the word big data is actually tied very well with the machine learning, which is actually synonymous with the AI, at least in the medical field, as predictive models are concerned. And then there is something, the automated planning, that you enable the algos to actually plan something or execute tasks. That's another area of computing. And I'm sorry if this is totally strange and outside medical field, but this is something I'm going to try to make it a little bit more simple here by showing you some studies. The computational learning is a lot of expertise which is required for machine learning. And this happens on certain softwares. But the fundamental understanding is biostatistics of applying this to medical sciences. And this is an area where you can use a language called R, but most frequently computer language that's used here in medical sector is called Python. And that's one thing that you can familiarize yourself with in order to do tasks if you wish to, because that's the feature of the medical predictive models. Even medical schools, we just found out that there's courses introduced on this one. The NLP perception is something that the medical field is well aware of. That's actually natural language processing. And radiologists have been using this for the past 20 years, that the artificial intelligence software recognizes their voice, and eventually it actually learns over time your accent, the words that you say, and it really puts it into document form. This has increased significantly over the cell phones, like Siri is an iPhone, and that's the classic artificial intelligence software that's recognizing 40 different even Arabic dialects, and even like Balochi language. It can differentiate between a person from different places of Balochistan. That's where the field of NLP has advanced to. And social journal intelligence, I'm not going to talk about today because this was the newer concept just of this millennium, and it becomes a little complicated. So, but that's a term in which actually the machine learning algorithms are so strong and so powerful that they can influence some decision making as well. But that's a field in development, not already existence. So I'm going to show you where we are today. This is the current millennium. This is an article published which is showing over time the research in different fields. And as you can see, the cancer field at the top bar is showing that the number of papers published in this area has significantly increased. This is up to 2016. It's 10 times more at the moment in 2020. But all fields, actually, practically, dermatology is one big one. I'm going to show you some data on that, but are actually looking into machine learning algorithms to help in clinical practice. But by far, the biggest field is cancer, hematology, and bone marrow transplantation. And this is all healthcare combined. So I'm going to tell you about the breakthroughs which have already happened in the healthcare industry. And one of the greatest breakthroughs that have happened is actually in the field of dermatology. Then a second big one was in the field of ophthalmology, in which the Google's AI company called DeepMind had already perfected an algorithm to detect retinal diseases. And this is based in London when they had mega data from NHS. And the third one just happened 2 months ago, and you saw the Nature paper and many different discussions in that and policy at NHS was on mammograms, screening mammograms. But let me go through the first one that made history. This was a paper by Stanford folks in looking at millions of images of the skin pathology, and they actually looked into how good a machine can be to identify a particular type of skin lesion and normal versus abnormal, and actually compared that against dermatopathologists, at least 14 to 16 dermatopathologists board certified. And then they actually compared how good is the diagnostic ability of the machine learning algorithm to detect cancers compared to dermatopathologists, each dermatopathologist against the machine, but then all 16 combined against the machine learning algorithms. Not surprisingly, they found the sensitivity and the specificity was much improved when you did that. And obviously, the time required for dermatopathologists to look into the whole case and render an opinion from 30 minutes to 60 minutes average in documented papers was probably 30 seconds or less to execute the whole scenario from issuing a report that this is your report. And this is the same for bone marrow biopsy report when the machine learning algorithms are being perfected now. They can look at the CBC connector, the genomics, and come up with the diagnosis within a few seconds, actually, which is a work of hundreds and hundreds of hours for 100 patients only to come up with the exact diagnoses. And they looked into benign, malignant, within malignant, is it melanoma, squamous, basal cell within melanoma subtypes, and the subtypes. But you need a training set of millions of images first. You need big data first in order to make that algorithm. I'm going to point out towards this thing called CNN, which you guys have been watching because of elections, but this is actually not the CNN TV channel. This is convoluted neural networks. So this terminology you will hear a lot called neural networks. And I've been talking about this at PSH and many other forums for a long time, actually. And we've done some studies. We published actually many studies on the neural networks, which is a type of machine learning in which you actually look into predictive models. So what's the role in hematology with this basics? I'm going to give you some papers, and then we're going to go over how we're going to do this if we were to think of doing it practically in a center in Lahore, Islamabad, Karachi, Peshawar, whatever, or any country, in fact. This is a article in Nature Communications of 30 AML patients and looked at the conventional statistical methods to look into pharmacogenomics, that which drug would be actually associated with an effect of genes. You see what's happening right now in the world is every time you make a targeted therapy or personalized medicine, which is overrated quite a bit, is actually you find after a few years that the drug was having a million other off-target effects, wasn't targeted to one pathway. But what if you put all the million pathways together, million targets together, and all the receptors together, and actually look at the same time the efficiency of a drug or a molecule or immunotherapy, or a chemotherapy or CAR T cells, and look into that what exactly is going to target or how many is going to target. So you have 20,000 genes in this and 53 drugs you were testing, and this is a typical algorithm that your statisticians do for drug development. But the merge framework, which was highlighted in this particular article, looked into the same 30 AML patient samples, bone marrow and blood. They had 53 drugs, and look at the interactions between the drug as well as the efficacy of the genetic mutation. You find out that there's many, many more pathways that each drug can affect and many more receptors. You look at a STAT pathway, JAK-STAT pathway, you look at the kinase pathways, you look at a million other pathways, and at the same time, you're putting a distribution for the driver features of each and every association that you make between the drug and genome. And these are the 5 different parameters that we're looking at. Methylation pathways like DNMT3 mutation, for example, copy number variation, mutation regulator, and hindness as well. I don't want to go into details of this complicated merge pathway, but suffice to say that this is the way the drug development is happening in the world now. Things have changed in order to find a drug that's going to work, because spent about $1 billion from preclinical to phase 3 trials in the US. And at the end of the day, how many are approved from FDA? Majority are not, because they're negative studies, either phase 1 or 2 or 3. So we got to do a better job. This is the same article looking at actually different weights to different properties of the association, which was done by machine learning algorithm. So by the way, this terminology is much more accurate for predictive modeling in medicine called machine learning, not the AI. This is a beautiful article by Good and colleagues that published a couple of years ago, in fact, looking at the B-cell ALL, the phenotypic and the functional proteins in single-cell analysis. And you can look at the principal component analysis called PCA, we call in pathology, of different cell markers by flow. And here is the PCA for the patient, unique patient ID, and you can see different associations that were being made by the machine learning algorithms, not by human interpretation only. And this could be done at actually, in fact, any flow cytometry machine and any PCR mutations that you have. But this is actually going to be looking. All you need is there's a 12 or 8 multicolor flow cytometry panel. And then you need to put in the software, which is going to devise and tell you exactly is it a hematogoon or not. And this article actually came out with certain predictors which we had never known for relapse of B-cell ALL. This is pediatric populations only. Ronnie Shuwal, he is in New York right now. He did one of the original articles from EBMT, looking at the predictors of relapse in bone marrow transplant patients in leukemias, and he found out that there's several different categories. I mean, we think of predictors of relapse based on cytogenetics of for example, AML, the ELN classification I showed you. But then you put all these factors that I actually mentioned earlier on, including the number of drugs they're making for you. I'm just giving an example. And you come up that the people have very different outcomes based on many different parameters. Because if you want to put every single social determinant, every single physical comorbidity, age, gender, and many million other factors that you can put in one equation, then you can get a much better predictive model, because you do a univariate analysis with 15, for example, variables that we think are important. But then how many actually go into the multivariate regression analyses? The ones that are actually going to be fit, I mean, up to 5, and then you lose the power. But here you can do thousands of variables at the same time, multivariable logistic regression or linear regression analyses. So this was clear, actually, that when this paper came out, that the world really needs better models based on machine learning. I did another model based on the data I had from King Faisal and Riyadh, and we looked into 7 different models of patients who got a homogeneous conditioning regimen and were sibling transplants, and we looked into the sensitivity and the positive predictive value, negative predictive value. You can see the sensitivity increases to 0.837 with the random forest model, and that was a model which is actually one of the most studied model anyways. But either way, if you look in all the different models that we did, bagging and the KNN, MPL, we're not going to talk about those today, but they had significantly increased sensitivity and precision as well. So you're not looking at sensitivity and specificity only with machine learning algorithms, but you're looking at NPVs and PPVs as well. So a very nice article by the NMDP group in Minneapolis, looking at the predictors of utilizing the unrelated donors of bone marrow transplant registry. And actually they found out something we would have never found out. That is change of address, a DC code, other indicators, races actually came forth of when a donor is called for donation, that what could actually affect. This is millions and millions of data points. And that's how people actually do machine learning algorithms to predict that what if we're missing something, and this is what you find. This is Jocelyn Gandelman from Vanderbilt. She did with Madan Jagasi the study, looking at the probability of chronic GVHD-free survival. And surprisingly, there were categories that the machine learning algorithms found. The joint and fascia scleroderma, your actually risk of GVHD-free survival is right here, significantly different than other clusters. So actually, you're clustering different organs rather than thinking, okay, it's the donor characteristics in the past, or the chemotherapy that you're going to use, like ibrutinib, ruxolitinib, BCP. But actually, it depends on the disease organ manifestations. And these were 7 clusters that they found. I'm showing you cluster number 2. So much better accuracy, but also you're coming up with new stuff that you had never known, actually, that somebody has joint and fascia compared to oral and skin only, and scleroderma, and somebody has liver. The outcomes are extremely different. This is another medication published by another Dr. Lee. She's actually in renal transplant in Boston, a Catalyst, Harvard Catalyst, and looking at the acute GVHD prediction in different models were here, acute, low, and medium. I'm not going to go into details because we were surprised when we looked at the CIBMTR data predicting such different outcomes based on different variables. And you can have any variable from telomere length to study, from pre-transplant variables of the donors versus recipients, and other factors as well. Suffice to say, this is actually 3 different categories for acute GVHD risk. And once you have this machine learning-based algorithm based on the pre-transplant characteristics, you can actually increase or decrease or have mitigation strategies for acute graft-versus-host disease based on this particular paper. This is another paper of looking at the relapse of pediatric ALL and looking at different ranked features of different variables that you can predict for relapse of ALL, because our traditional, really, we look at the cytogenetics, the FISH, and the MRD, which ain't enough at all by this. It clearly showed that there's 1,000 other factors that matter. And then you give weights for that for each of them as well, like a traditional statistical method. Now, this is something that I had no idea about, myeloma transplants, although, as you know, Mayo Clinic is the largest myeloma transplant center on earth. When you combine all the 3 Mayo Clinics in the US, the 200 autologous transplants only happening in Rochester, Minnesota. But I had no idea that when this study came out that, when you look machine learning algorithm for thousands and thousands of patients' data with million variables, you can actually come up with a mutation that I did not predict because our MSMART guideline for myeloma transplants was very different. The CHEK1 gene mutation actually was giving a huge difference in variation for outcomes post-autologous stem cell transplantation. And similar models are being applied for allogeneic transplants as well. But here you can see actually that depending the mutation, having a mutation obviously doesn't mean that you have cancer. But what mutation predicts how much prognosis, we don't know actually, and how much driver mutations versus bystander. You have to know which ones are truly founder mutations and which ones are not. And machine learning algorithms are way advanced now to predict those. And last, I'm going to show you actually, because I'm cognizant of time, but I have some time for discussion as well, is a QPOP. QPOP was a technique that was developed by the NUS, National University of Singapore, for drug development. And small amount of blood and bone marrow you take from the patients, and the platform is able to map the drug response, so you can have a set of drug combinations. This question always come up, that how many randomized clinical trials are you going to have, phase 3? Each trial costs, it's about $1 billion, or at least a few $100 million actually to conduct a phase 3. But what if you had an algorithm that you can put all the drugs together? Name any drug. You can put cyclophosphamide, Velcade, which is bortezomib, daratumumab, cyclophosphamide, bortezomib, melphalan, cyclophosphamide, and melphalan, steroids, and daratumumab alone, actually. And you study all the thousands of combinations in a patient's real-time blood sample. And you had a software which could actually pick up that which drug would work. Initial pool of 114 FDA-approved drugs, not like 10 common that we use or we think it's actually should be used, because unfortunately, because that's the way it is in our world of oncology hematology. Whatever the key opinion leader says at the podium of ASH, this is the new standard. Without looking at the costs and without looking at individualized medicine, that becomes standard of care. But they actually looked into all 114 generic and non-generic medications, and they identified a series of drug combinations, completely novel, unexpected combination that outperformed the standard care regimens for relapsed myeloma. This could be even simple as cyclophosphamide and prednisone may work for this patient better, rather than using all your really fantastic and extremely expensive drugs. And this is what we really need, actually, what works for a patient. And these techniques, when they're refined, actually, like the National Institute of Singapore is refining, can really help us in individualized medicine. We published another paper on the CLL, actually all leukemias, looking at the current classifiers used, and we looked at the sensitivity of different studies as a comprehensive systematic review, and we looked into the sensitivity and specificity was phenomenally high. But I would caution you that there could be technical faults like all of them. The field is actually 50 years old, actually, sorry, 70 years old when the first AI conference happened in Dartmouth. This is a long time ago. Socio-financial costs, maintenance costs are a separate issue, but they're significantly less than actually having human resources. Privacy issues or cybersecurity is something that we're dealing with every day. There are probably 1,000 articles on cybersecurity issues and cloud issues already, published in healthcare specifically. The question comes, is it going to take away the human instinct or not? Absolutely not. It's just a tool to help us in diagnosis and management. Obviously, the physicians will always be there to talk about life and death decisions. There's no question about it, actually. People have thought that in pathology and radiology, it may change the world, and it's true that it's changing the world. But when it comes to the patient-doctor relationship, it has nothing to do with the oncologist or hematologist talking with the patient. Obviously, all the novel ideas come with generation. Now, in 2018, there were no insurance coverages, but now things have changed. Actually, I'll show you something. So this is my question to all the audience today. Is there any artificial intelligence-based software that's approved by the United States FDA currently? And when I'm talking about giving these talks, actually, I get an answer that yes, there is one, and there's another one. Some people say no, and then is it going to be 5 years, 10 years? I always get a big shout from the audience that it's never going to happen. Well, the answer is in 2018, the first software was approved for machine learning algorithm to diagnose things, and that was for the CT scan stroke diagnosis, and then multiple cardiology have been already approved, just like drugs are being approved. So this is real. This is not sci-fi. This field has been there for 70 years, and now with the past 3 years, we have seen a lot of approvals to be used. For example, CT scans for stroke diagnosis in the ER is already approved because these were better, quicker, even to give TPA or not TPA. And same thing with many other conditions, in fact. So it's a reality, like a drug approval. So no longer it's just something that you should not invest in thinking about. The world has changed significantly. This is 2016, 2006. Today, all the tech companies are actually ruling the world as far as the biggest market share is concerned. So I'm going to stop here and indicate that, our medicine is an oral science and our patients will always be communicating with us. So think of this as a tool, like all the other tools, to help you. And don't even bother reading all the hype in the media, which is like, it's going to replace humans. It's never been that case. And it was never the intent either. It's actually going to be helping us in daily diagnosis to reduce our time, and reduce our time to spend more time with the patients face to face. So that's what my message is going to be. With that, thank you very much for listening to me.
Thank you very much, Dr. Shark. That was very interesting. The first thing that crosses my mind, and probably many of the audience, is that it might take years before it reaches this part of the planet, but definitely the way forward. Okay, and now we will invite our third speaker, Dr. Usman Sheikh. He is Associate Professor, Clinical Hematologist in Aga Khan University Hospital, Karachi. And he has a challenging topic of management of hemophagocytic lymphohistiocytosis. He's going to share the local experience with us. Dr. Usman Sheikh, over to you.
Thank you, Dr. Bushra, and Assalamu alaikum to all the listeners. The topic which assigned to me is the management of hemophagocytic lymphohistiocytosis, a local experience, and I have no conflict of interest. I just started my talk with an example which we recently see a patient in our hospital is a 40-year-old female admitted with fever and weakness for 1 week, and examination revealed splenomegaly, which was 16 centimeter on imaging. Complete blood count revealed pancytopenia with a hemoglobin of 8.9 gram. White cell count was low with a platelet count of just 4,000. Viral serology was negative for HIV, herpes simplex virus, cytomegalovirus. Malaria was also negative. However, patient revealed positivity to dengue antibodies, mainly to IgM. Blood smear was inconclusive and marrow spirit was hypocellular. So bone Trephine revealed actually a cellular specimen showing these macrophages, actually histiocyte engulfing red blood cells, which is more prominent on this slide. One can easily notice these RBCs, numerous RBCs engulfed by these histiocytes and macrophages. We did CD68, which is a histocytic marker, which was positive in these cells, and this CD31 is actually an endothelial marker, but one can easily appreciate the beautiful picture of CD31, which is on the immunohistochemistry, which is picked by these hemophagocytic cells. So at the time of presentation, the patient had a very high ferritin, 71,000. Liver function test was also abnormal. Fibrinogen was very low. Hemoglobin, as I mentioned already, with severe pancytopenia. We have started injection dexamethasone for 10 days or so, about 10 milligram twice daily, intravenous, and it is currently on tapering dose orally. So in conclusion, this case was actually the dengue-induced secondary HLH. On the latest laboratory investigation, we can notice a marked increase in improvement in overall laboratory parameters. Now, hemophagocytic or lymphohistiocytosis is actually first described by Scott in 1939. The familial origin was first recognized by Shaukat in 1952. It is actually a progressively and potentially life-threatening disorder. We can easily imagine that the survival is just 5% at 1 year if we don't offer any treatment. Most of these patients died within first to 2 months of treatment if intervention is not applied. So it's a disorder secondary to abnormally increased activity of immune system with release of inflammatory cytokines. It is a rare disease, no doubt, predominantly affecting infants. However, it can observed in any age group. Overall incidence which is reported is 1 per million. However, in a tertiary care hospital, it is noted that is approximately 1 out of 3,000 pediatric admission, one patient is actually having HLH. Pathogenesis primarily involves T cells, mainly cytotoxic T cells, macrophages, and natural killer cells. This is a beautiful slide, which was published in BJ Heme by Jordan et al. In 2011. Actually, the main pathogenic mechanism is that whenever there is a trigger, say for example a target cell or tumor cell or target cell with infected infected organism, what happens? These T cells just create some synapses in it, and through these synapses or paths, what happened? Some granules with the name of grazine is entered, leading to a process of apoptosis. Now, because of some genetic mutations, what happened? The process of docking, priming, and fusioning not happening. That lead to, but the trigger is present. So that's why there is an enhanced response of immune system with the collection of macrophages and T cells at the site of trigger. There are long list of molecular defects. However, especially in the primary HLH, which predominantly happen in children and infants, approximately 40 to 80% of these children reveal abnormality. However, with increasing age, the overall defects, the frequency of defects decreasing with increasing age, and it is up to 15 to 20% in adult. Now, what happened because of the collection of many histiocytes and other cytotoxic cells, there is an increase in the cytokines, overall increased production of cytokines in the body. And the first, which was observed in 1989, is a raised level of soluble interleukin 2, which is also known as soluble CD25. The commonest mutation which are noted is the perforin 1 and UNC13D, and majority of the patients usually have these two type of mutations in these patients. Diagnosis is challenging in these patients. Why? Because it's a rare disease. Number two, there's a variable presentation and not a single parameter. There is non-specific single diagnostic parameter. So variable presentation, and there are numerous non-specific findings. So high index of suspicion is required whenever there is a strong family history. Say, for example, there is a history of a death of a sibling in the family, younger age, cytopenias with organomegaly, including hepatosplenomegaly. Serum ferritin of more than 500 is sensitive, but it is not very specific for this disorder, because in other bacterial and viral infection we can see increased ferritin. However, serum ferritin of more than 10,000 carries more than 90% sensitivity and 96% specificity. But on the other hand, a ferritin of more than 50,000 is less sensitive and only noted in 19% of HLH patients. However, more than 50,000 of serum ferritin is usually noted in patients with renal failure, hepatic failure, and some other hematological disorder. In adult, yes, whenever there is a prolonged cytopenia, unexplained cytopenia in an adult with underlying viral infection, autoimmune disorder, malignancies, one should rule out the possibility of secondary HLH. From infection point of view, among the viruses, the EBV is the commonest one. And from fungal infection perspective, histoplasma is the most common organism in these patients. In approximately 1/3 of these patients manifest neurological signs and symptoms, which include seizures, meningismus, altered level of consciousness, cerebral palsy. It has been seen the hemophagocytic feature in CSF, and in these patients, approximately 50% patients revealed abnormality in CSF. MRI showed discrete lesion to diffuse leptomeningeal disease. Peripheral neuropathy is also not uncommon. Now, how to diagnose? In 2004, from the society, the diagnostic criteria was published. In this, there is no issue with, we can easily see patient with fever, splenomegaly, on clinical examination with fever, splenomegaly, cytopenias. However, in our part of the world, the natural killer cell activity as well as serum interleukin or soluble interleukin 2 measurement the facility of these tests are not available. However, on the other hand, in 2014, another paper published which uses the more common variables, which include organomegaly, presence or absence of febrile illness, number of cytopenias, level of ferritin, triglyceride, and fibrinogen as a liver function test. So, and scoring was performed in approximately 340 patients. And this scoring, which is nowadays known as an H score, got more than 93% sensitivity and 86% specificity. The beauty of this scoring system is that it didn't require any soluble interleukin 2 measurements, or we don't need to measure the natural killer cell activity. It was validated, and especially it is very useful in the initial diagnosis. So nowadays, people are more and more use this H score in clinical practice. Now, what our experience in Aga Khan, we try to get some data from Pakistan. So I searched the Google for it. However, only case reports from Pakistan. So as when I planned to prepare my presentation, I just prepared to look for some other data. So it's actually a retrospective analysis of 10-year duration of from July 2010 to June 2020. Inclusion criteria was patient of all ages and gender, and diagnosis of HLH with the heading of primary, secondary, acquired, or macrophage activating system, all were included, and we use H score for calculation in all cases. So we retrieve 55 patients, overall total patients, and out of those 55, 51 were available. Provisional diagnosis of primary HLH was noted in 41. Why provisional? Because the facility of genetic mutation for HLH is not available in our part of the world. Secondary HLH was seen in 10 patients, and pediatric population, especially in the primary HLH, was approximately 87%. Out of 41 total primary HLH, 36 belong to pediatric age group. And this is the further description of primary HLH. And one can easily note it that most of these patients, more than approximately 55%, were less than 1 year of age. So this is basically a disease of infancy and childhood. Apart from that, there is a male preponderance as compared to female. History of a death of a sibling in the international study, it is approximately 40%. However, in our study, it was just 12.2, because at the time of admission, the physician or resident unable to ask about the death of a sibling. From laboratory parameters, we have seen almost all of these patients had pancytopenia with deranged liver function, and ferritin was noted in a range of from 1500 to 14,000 with a median of approximately 6,000. Fibrinogen was low in a number of patients. Hemophagocytosis only noted in 41% of these patients, although it ranges from 40 to 80%, but here we have seen only in 41%. H score was more than 169, which is a cutoff which we use in approximately 73% of these patients, and the median H score was 188. Now, out of those 41 patients, HLH protocol was used in approximately just 13 patients, as compared, and another 25%, that is so another 25 patients, that is approximately 61%, receive steroids. Other immunosuppressives like cyclophosphamide or cyclosporin were used in just 3 patients. So majority of these patients, out of these 41, 56% died till the last follow-up. The median follow-up was just 11 weeks, because most of these, with the use of steroid, what happened, there is a dramatic improvement in the clinical manifestation. So patient usually once improved, they just lost to follow. So variable which affect the outcome in primary HLH, we have seen that those patients who have a high ferritin level usually did poor to either steroids or to HLH protocol. Similarly, those at the time of presentation have a low fibrinogen level also did poor. This was survival, as I mentioned, according to the treatment received. Those patients who receive HLH protocol, they have actually somehow better survival as compared to those who achieve only steroids. Now come to secondary HLH, which we as we are looking those patients who are adult in our hospital. So overall 10 patients we observed in last 10 years. That's when it is rare disease, no doubt. You can easily assess that one patient in a year we usually see on consult. Again, most of these patients have pancytopenia. The important thing is that some of these patients have a very high ferritin level. Say for example, 165,000 in some patients with, especially with Still's disease. Fibrinogen is not too low as compared to primary HLH in pediatric patients. Similarly, hemophagocytosis is less common in adult as compared to pediatric patients. H score, yes, H score is high in these patients, and especially H score of 169 is noted in more than 90% of these patients. And the overall outcome and the underlying disease process in the secondary HLH in adult patients, most of these patients actually have viral infection like CMV, HIV, and H1N1 influenza. 3 patients had Still's disease, and 2 patients had lymphoma. One had peripheral T-cell lymphoma, other one had Hodgkin lymphoma. Most of the patients who have viral or autoimmune etiology received steroids. Out of these 10 patients, 4 patients expired because of the disease progression. Now, a few words about the transplant. It is important to note that chemoimmunotherapy which patients receive according to either HLH 94 protocol or HLH 2004 protocol cannot cure this disease. This is actually used as a bridging for transplant. So allogenic bone marrow transplant is the only curative treatment option. However, few things are important before transplant. One is to look for the donor who should be, and he should be tested for genetic mutation. However, it is important to note that even with mutation, if the donor just have heterozygous carrier, then he can be taken as a donor, and apparently there is no negative effect. However, the soluble CD25 facility is not available in our part of the world, but it is one of the most important tools to assess the timing of transplant. Low level of soluble CD25 is the important parameter to proceed for transplant. Conditioning regimen historically, myeloablative conditioning regimen used in these patients is Bucide with addition of etoposide plus minus or antithymocyte globulin. Despite all these efforts, however, there is a high transplant-related mortality reported, which is up to 50%, secondary to infection, veno-occlusive disease, pneumonitis, graft failure, GVHD, and the most important thing, which has been seen in this patient, is the reactivation of HLS in the post-transplant phase, especially in the first 100 days of transplant. People use reduced intensity condition, including fludarabine-based conditioning regimen, melphalan and alemtuzumab. And in some protocol, ATG was also used. Now, Marsh et al. Judith Marsh et al. Reported a 3-year survival rate of 92% in their reduced intensity conditioning cohort, when compared to only 43% in their myeloablative conditioning cohort. However, it is worth mentioning there is a high incidence of mixed chimerism and graft failure in reduced intensity conditioning. So, in conclusion, HLA is a rare disease. However, it always consider in the presence of a positive family history for, especially in a death of a sibling, persistent cytopenias, and hepatosplenomegaly. We should use our high index of clinical suspicion, especially in adults with viral infections, autoimmune disorder, and malignancies who are showing unexplained prolonged cytopenias. And as I mentioned, there are actually there are only two scoring systems are available. However, we have seen, and it is already validated, that H-score is more useful because it uses those variables which are available in our part of the world. So I recommend the use of H-score in our part of the world because the testing facility for natural killer cell activity as well as for soluble interleukin 2 is not available. Thank you.
Thank you very much, Dr. Osman Sheikh. That was very comprehensive and a good collection of data from adults and PET side. We have a question and answer session at the end. We will go to our next speaker so that we can give her a few more minutes, and then we'll have question and answers at the end. Our next speaker is Dr. Su Wai Mong. She is a consultant hematologist in Mater University Hospital, Dublin, and she's an expert in MDS. And we are looking forward to hear what she has to say about updates on management of MDS. Over to you, Dr. Mong.
Thank you very much, Bushra, and I hope you can hear me all right. And
yes, I can
greetings
hear you.
From Dublin, Ireland, and I'm delighted to be here, and thanks very much for your invite. I have no conflict of interest to declare, and I have to say I am first and foremost a clinician looking after a wide variety of hematological disorders. I also take a very active role in undergraduate and postgraduate medical education through UCD Dublin, which is affiliated with our hospital. My talk is going to be structured in more practical aspects and highlighting the updates in the management of patients with myelodysplastic syndrome, and I will share a few patients of mine with you. As we all know, the hallmark of the myelodysplastic syndrome is a dysregulated hematopoiesis resulting in the impaired differentiation, marrow dysplasia, giving rise to peripheral blood cytopenia. The cells of origin in MDS are hematopoietic stem cells and progenitor cells, implying that the only possible cure for these patients is a stem cell transplant. There is a complex interplay between the genetics and epigenetic alterations, bone marrow microenvironment, and immune system. And these changes and these processes can evolve over a number of times. So my first observation is this is a very challenging disease because it's complex. There is a complex disease mechanism, the heterogeneous presentation, and the prognosis, and not to mention that even though there are a lot of potential disease targets, the therapeutic options are actually less abundant. And diagnostic process, all we know is that it's very challenging in itself, even with the advances in the molecular studies and identifying some of the mutations that we see here, and and highlighted in red, carrying the negative impact with only one mutation highlighted in blue, carrying a positive impact. These investigations are actually not readily available to a lot of the clinicians, and the turnaround times are not actually very practical. So, and however, we have to put these into prognostic scoring system as described here to guide our management, noting also that we're dealing with the older cohort of the patients who would have a high number of comorbid conditions. So formal assessment of their frailty by the use of other formal comorbidity index such as Charlson or MDS-specific comorbidity indexes has been increasingly popular in clinical practice these days. As we know, the higher risk MDS patients are aim is to delay the disease progression to prolong life, whereas the lower risk MDS patients to maintain and improve their quality of life, and cure is only possible in a fraction of the patients. So my second observation is that risk-adapted management approach remains a standard practice for our patient, dividing these patients into two broad categories for the approved therapies with supportive care for both, and frailty and the fitness of the patients will also be an important consideration when we choose appropriate therapy for higher risk MDS patients. We'll be talking about these approved therapies in detail, but also take some time to focus on the some of the new emerging therapies which has obtained FDA fast track designation. So my third observation is that supportive care remains the cornerstone in management of MDS patient, not only physical, but also psychological well-being, because this is a devastating illness with a huge emotional and financial burden to the patient and the family. So what about the transfusion? What should be the optimal hemoglobin target? I am disappointed to say that there is no high quality data, and the Nordic study group has described that quality of life is improved with high hemoglobin values, but the UK study also showing that the higher transfusion targets are associated with improved patient outcome, but my take is it is individualized. Extended matching of the red cells antigen like rhesus and KEL are increasingly used in clinical practice, but the clinical benefit remains unclear. Let's look at the platelet transfusion. And so the guideline is that only transfuse if they are bleeding and if as a supportive care as part of the hypomethylating agent or chemotherapy. Iron overload has been increasingly recognized as major contributor to poor outcomes. However, clinical utility of iron chelation in these group of patients is very challenging, and it remains debatable because of their comorbid diseases and underlying hearing or a visual impairment. But it should be considered definitely for patients who are going for transplant or patients with high transfusion burden with reasonable life expectancy. What about prophylactic antimicrobials? All neutropenic patients are giving antibacterial, antifungal mouthwashes. We don't give flu vaccine for patients who are has a neutrophil count of less than 0.5 so that we can prevent the febrile episodes. Prophylactic antibiotics, the practice varies from place to place, and certainly this is not a practice here in Ireland, but we do give posaconazole as an antifungal prophylaxis for high-risk MDS. Let me introduce to my first patient, Mr. B, who is 66-year-old, and he's just retired. He's a retired nurse and went to the GP for routine bloods and found to have pancytopenia. He's a bit fatigued. He has dysplastic features on the peripheral blood, and bone marrow show trilineage dysplasia with 8% blast, so WHO MDS excess blast 1. Karyotype is normal, IBS-SR is intermediate risk. So what would be his treatment options? The approved therapy for the managing anemia include erythropoietin-stimulating agent, which has been around for ages, lenalidomide or luspatercept, but there are a few exciting agents coming down the line. We all know that erythropoietin-stimulating agents are very useful and for low-risk MDS patients, especially patients who have a low endogenous erythropoietin levels or patients with low transfusion burden are highly responsive. I don't need to go through all of this with you because I think you all have known about this. I would usually add GCSF if they don't respond, but the patients should ideally be treated before they become transfusion dependent. Here's a few exciting papers for you to read. What about GCSF? It is not recommended just for having neutrophil count, low neutrophil count alone, but may be useful as a supportive care, part of the hypomethylating agent treatment. L-Thrombopec and romiplastim are actually not licensed in any risk of MDS, even though there are positive results observed in the pivotal study. The support study studied an AZA plus or minus L-Thrombopec in intermediate to high-risk patient as a phase 3 trial, but the results showed that the L-Thrombopec did not improve patient outcomes. It could be useful for patients with bleeding and severe thrombocytopenia in hypoplastic MDS patients. What about lenalidomide? In 2006, Alan Liss and colleagues reported the results of the MDS-003 trial, and which show that the lenalidomide can improve the transfusion requirements and restore the erythroid activity, and also can induce cytogenetic remission. These results were further confirmed in the phase 2 and 3 trials, and 2 years later, and Azaraza and colleagues in 2008 has reported another phase 3 study showing that lenalidomide in non-del(5q) MDS patients can also have a erythroid response, and that lenalidomide can induce sensitivity of the erythroid cells in MDS to erythropoietin. This has led to FDA and EMA approval of lenalidomide. But it is worth noting that if the patients have TP53 mutation, that can negatively impact the outcome and response of the lenalidomide. So, and consider do not give them. More studies and on non-del(5q) lower risk MDS and patients treated with lenalidomide and hypomethylating agents. But noting that hypomethylating agents are licensed for all risk group of MDS in the US, but we only have the licensing and funding application for high risk MDS for AZA and decitabine. Let's talk about luspatercept. So transforming growth factor beta ligands are interferes with the signaling pathways. They have negatively regulate the later part of the erythropoiesis through the SMAD2 and 3 signaling. Luspatercept is the first in class ligand receptor binding fusion protein, and that interferes with the SMAD2 and 3 signaling so that it enhances the late stage of erythropoiesis in some of the MDS patients. We all know about the Medalist trial, which was presented by Trephine and colleagues first in 2008, and the results were updated a year later in ASH 2019 and EHA 2020. Medalist study looked at MDS patients who are refractory or intolerant of ESA, who are transfusion dependent, and with lower risk MDS with ring sideroblasts. The results, patients, I won't go through these in detail, but I would like to point out that the results were astounding. The study reached its primary endpoint early. The primary endpoint is transfusion independence at 8 weeks, which is 38%. And I believe that in ASH 2019, they updated these results to 47.7%. It is also worth noting that about a quarter of the patient experienced fatigue, and 2 patients have withdrawn from the trial because of fatigue. Luspatercept has an FDA approval, but for Europe, and it has received a positive evaluation. Different European countries have different access. We certainly, Ireland, and are still waiting for the funding approval. So far, I think I have pointed you out that in lower risk MDS patients with del(5q) start with lenalidomide. Without the del(5q), with the low serum erythropoietin levels and low transfusion burden, I would use the ESA followed by the lenalidomide plus or minus EPO, or consider azacitidine. Without the del(5q) and with high serum EPO levels and transfusion burden, I would start with lenalidomide plus or minus EPO or azacitidine for the older patients. For the younger patients, we can still consider immunosuppressive therapy, which is leading me to the next slide. But my take for immunosuppressive therapy is for patients as a second line after failure and for hypoplastic or normoplastic MDS. But for the younger cohort, you would really be thinking about transplanting them. Let me go through a few investigational agents such as azacitidine or CC486. This was FDA approved for maintenance therapy in AML, but the CC486 and lower risk transfusion dependent and anemia and thrombocytopenia patients in MDS, the results are long awaited and only recently been available. So the primary endpoint is transfusion independence at 56 days, which is 31% compared to placebo. The study does not show any overall difference in overall survival, but this study is underpowered for sample size. And more early deaths, especially related to infections, are related in the treatment arm, but the overall death rate was similar. The next one that I like to talk about is the telomerase inhibitor emeltastat. Shorter telomere length and high telomerase activity predict shorter overall survival in MDS patients. So IMerge study is looking at the lower risk MDS patients and with transfusion dependent and refractory to EPO, which is a single arm open label trial. The study numbers are small, and the primary endpoint is the transfusion independence rate at 8 weeks, and it showed very good results at 37%. And I think the phase 3 study now has shown that 42% response rate. It is worth noting that a significant number of patients, about 25%, experience neutropenia and thrombocytopenia. Let's meet my second patient, Mr. C, who is a 74-year-old gentleman who attended ED with a chest pain, which is late diagnosed as non-cardiac. He had very significant past medical history. He has ischemic heart disease and bypass surgery, lobectomy for lung cancer, radiotherapy for prostate cancer, diverticular disease, and bleeding duodenal ulcer just 2 years ago. He has normocytic anemia, but WBC and platelets were normal, but he had the 3% circulating blast cells with features of dysplasia. And bone marrow showed trilineage dysplasia, 8% blast. So he could be MDS, EB1, or therapy-related MDS. A week later, cytogenetic results available showing that he has a very complex karyotype involving the chromosome 3, 5, 7, 11, and more than 3 abnormalities. So he has a very high-risk cytogenetics. So his IPSSR is very high risk. What would be his treatment options then? So my next observation is that hypomethylating agents remains the standard of care in the real-life practice for majority of the high-risk MDS patients. The mechanism of action of azacitidine is complex and involving from DNA hypomethylation and cytotoxic activity to immune-related and epigenetics. Azacitidine is approved in EU who are patients ineligible for transplant, intermediate 2 or high-risk MDS or non-proliferative CMML, but in the US, it is approved for all risk group of MDS. This is based on the AZA-001 trial that we all know and which showed improvement in survival in azacitidine arm for 24.5 months compared to 15 months, and with patients receiving best supportive care. There are survival benefits for patients who would respond to, and with CR and partial response, complete response, and platelet response early on can predict these survival advantages. We know that there are a lot of mutational data and mutational profiling and trying to estimate or predict the response of azacitidine, but the current data is quite disappointing and there is no good quality data. So unfortunately, we can't predict who would respond to azacitidine. Azacitidine only reduce but will not eradicate the abnormal clone, so relapses are inevitable. What about decitabine? Well, there are no phase 3 studies. Only phase 2 studies are available for MDS with an overall response rate of 40% and could be useful for bridging therapy. And it is worth noting again that MDS patients with TP53 mutations are highly responsive to decitabine. And this slide is showing that patients have a very impressive clearance of the TP53 mutated clones after being treated with decitabine, and that's in both MDS and AML. Limited data is available for intensive chemotherapy. Surely we don't see that a lot. We don't do this a lot. May be useful as a bridging or after the hypomethylating agent failure if they are fit, but the response rate in MDS are much lower than that for the de novo AML. Then let's meet my last and final patient, Mr. F, who is a 61-year-old. He is a retired naval officer. He was treated for JAK2 positive ET with hydroxyurea for about 10-15 years, and then recently was diagnosed in another institution with MDS with excess blast 2 and with fibrosis. And this could also be myelofibrosis transformation from ET, but he is very dysplastic. He has acquired trisomy 8, and the mutational screening only showed JAK2, and there was no evidence of TP53, even though his hemoglobin and platelet count is normal. His Pfizer count is elevated with significant circulating blast. He's just literally on the brink of transforming to AML. He has significant past medical history with ulcerative colitis and on anti-TNF agent. He has well-controlled primary sclerosing cholangitis, and his liver function tests were actually normal. But this gentleman, Mr. F, is a very fit gentleman and he runs every day. He showed me the record on his phone that he had to run 135 kilometers the month before. So he basically came to me for the second opinion. And so what shall we do with him? So I'm not a transplanter, but this is my take on the transplant. So it is fair to say that long-term disease control with the transplant is up to 45%, but about 1/3 of the patient will relapse. So we'll have to choose our candidates very wisely. Age is no longer the major determinant selection criteria, but the patient has to be fit. Fit in the names of very good performance status with Ganowski score of more than 60 with very little comorbidities, and preferably do not have a huge transfusion burden. In terms of the disease, high-risk patients who are fit and have a donor, we should proceed. For lower-risk patients, if the disease is progressing very quickly or having very high-risk cytogenetic or molecular profiles, and we should refer them early on. Availability of a sibling donor can be challenging in these patients, and we rarely do have problems finding a match and related donor in this day and age. The choice of the conditioning regimen or pre-transplant bridging depends on a number of factors, but hypomethylating agent is currently our treatment of choice for these patients. Relapse post-transplant and is also recognized. So strategies such as DLI or hypomethylating agent to investigational therapies to tracking the patient-specific mutations are employed. The interactive decision-making tools such as this from MDS Europe can be very, very helpful, and especially when you counsel the patient in clinic. So for Mr. F, he does not have any sibling donor, but a match unrelated donor is identified. We gave him AZA and RUX with a good response, but I also gave him a mild CKD from chemotherapy. He was cytopenic as expected and required transfusion, but still runs about 2 to 3 miles every day. Recent MRI show query early cirrhosis, so he is having more investigations, but if all being well, we will proceed to transplant in December. So I will spend the last few minutes of my presentation about emerging investigational therapies, especially the ones that we should be watching out for. So we are living in the era of immune checkpoint inhibitors, and epigenetic modifications by the PD-1 inhibitor is a well-established treatment pathway for many solid tumors and is being considered as a treatment approach for the high-risk MDS patient. BLASCA2 trial and looking at 2 groups of patients, untreated high-risk MDS patients or patients after hypomethylating agent failure. If they fail, they're giving single agent, and if they're untreated, they're giving together with hypomethylating agent. So the results are very impressive for the frontline setting in combination with AZA, that even though the numbers are very small and its response rate are 62 to 70% with a very good CR rate in the nivo arm, but it is very disappointing in the patients with the HMA failure. IDH1 and IDH2 mutations are detected in about 5 to 12% of patients with MDS. So targeting these with ivosidenib for IDH1 and enasidenib for IDH2 have been explored. These are all phase 1 trials. Numbers are small, follow-up is quite short, but the results are good. So these are something to watch out for in future. BCL2 is overexpressed in many myeloid malignancy, including MDS, and responsible for maintenance survival of myeloid cells and resistant to chemotherapy. And venetoclax has also been studied in basically mostly in AML with very good results in combination with chemotherapy or AZA, but also in MDS. So for the treatment-naive high-risk MDS patients, there are 2 phase 1b studies available. And for relapsed refractory setting, there's 1 phase 1b. Reported overall survivals are good, and 63% of the responders proceeded to allo transplant. So, and we need bigger studies to clarify that. Rigosertib is a multi-kinase inhibitor that targets the RAS pathway, which is frequently mutated in MDS and responsible for leukemic transformation. And synergistic effect of rigosertib and AZA has been shown in vitro as well as in phase 1 and 2 oral rigosertib study. INSPIRE study was designed to assess the efficacy and the improvement in survival of these patients who are refractory or progress through HMA therapy. But it is disappointing that the study failed to reach the primary endpoint. Magrolimab is the anti-CD47 monoclonal antibody. So it interferes with the macrophages, and the tumor cells usually send signals to block the macrophages from engulfing them. So this is going to overcome that, so that malignant cells can be ingested and taken away from the system by the macrophages. Phase 1b non-randomized studies results in combination with AZA are very promising. So they have designed and opened ENHANCE study, which is a phase 3 multi-center double-blind randomized control study of magrolimab plus AZA or placebo plus AZA for high-risk untreated MDS patients, and started recruited. Our center has been identified as one of the potential sites, and actually we're having a pre-site visit tomorrow, so fingers crossed. I cannot talk about novel therapies without mentioning APR-246, and which is a TP53 modulator. It's a novel small molecule that can restore the wild-type conformation to mutant TP53, because TP53 mutations are detected in about 10% of the patients with MDS and AML, and we all know how adverse the outcomes for patients with the TP53. There are 2 phase 2 trials, one from the French group and one from the Moffitt group from the US. And the numbers are in the 50s for the study numbers, and the results are quite good, but bigger studies are needed. So they're planning for the phase 3 with or without azacitidine. It is noteworthy that their reversible neurological toxicity, which are dose dependent, has been identified in this trial, but watch this space. And this is just the Moffitt study. I will just skip it for the sake of time. So I think so far I have shown you that how little approved treatment for high-risk MDS has been available over the last number of years. So AZA was approved in 2004, followed by 2006 by decitabine and LEN for del(5q) MDS, but nothing approved for the 14 years until recently for luspatercept, but that's for low-risk MDS patients and with the ring sideroblasts. Depot agonist, venetoclax, ivosidenib, and perhaps immune checkpoint inhibitors are available for other treatments, other malignancies, but they're not licensed. So there's a huge unmet need in patients with high-risk MDS. Last but not least, I like to highlight that patient is the focus, and the patient and the carers and the family needs to understand this disease, and education and patient empowerment is the key. They need to understand what it takes and what can happen in the future so that they can stay informed and enroll in the clinical trials, and if possible. In terms of the treatment, decisions are made in conjunction with the multidisciplinary team, as well as the patient and family should be involved. And if they need a transplant or if they are potential candidates, we should be referring them to transplant centers sooner than later. Staying well is very important in MDS in both the physical and mental aspect. So our multidisciplinary team in here with the dietitian, physiotherapist, psychologist, social work, and clinical nurse specialists are engaging with the patient so that they can remain well. Patients should have clear treatment plans about what the treatment flow is going to be so that they can also make plans. It is a devastating illness, and a lot of questions that we get asked, as it will be the same with you, is that how long do I have left? Will I still be able to work? And do I need to make arrangements? Do I need to make a will, etc.? So in summary, and this is very challenging and complex, and especially for 25-minute slides. Risk-adapted management therapy remains the standard practice, and the supportive care is the cornerstone, so should not be dismissed. There are new therapeutic options which are exciting for lower-risk MDS patients, but hypomethylating agents remain still the standard of care. But I think the future is targeted treatment in combination with hypomethylating agents going forward. Transplant should be considered in fit and eligible patients and should refer early. And multidisciplinary approach is the key to the comprehensive management of these patients. And with that, I would like to thank all of you, and we're happy to take any questions.
Thank you very much, Sue. That was a very knowledgeable talk, and keeping us abreast of all the latest in this field. Now I will hand over the session to Dr. Usman Ahmed, my a colleague who will take the Q&A session and moderate through it.
Hi, thank you, Dr. Bushra. So I think I'll start questions from Dr. Mong, if that is okay. Again, a very, very good and exciting talk from Dr. Mong. Dr. Mong, can you hear me?
Yes, I can. Yeah, please go ahead.
So I think the first question which is coming in our mind is that your experience in the context of use of lenalidomide in non-5q minus patients with MDS, and are using any prophylaxis, any issues with cytopenias? What's your experience?
And we are using quite a lower dose. So I would usually start at 10, but I would, I'd be happy to go down to 5 milligrams if they are responding. I would use GCSF, and if they become cytopenic, to support them through. And for prophylactic antibiotics, I don't use them except for the antibacterial and antifungal mouthwashes, but only when they are neutropenic. But we can't use posaconazole for low-risk MDS patients and in Ireland. So, my hands are a bit quite tied. But the experience so far has been good. And we're fortunate that they are not following who is getting lenalidomide and for what reason. But I think things could get quite tight, with the control of the funding of these expensive medicines.
That's very kind. And you don't use any DVD prophylaxis, I would imagine, as you mentioned in your
It is not recommended, and sometimes it's not possible. Now, it is individualized, so I would do individual risk assessment. And if they have any history of VTE in the personal or family history, I would consider giving them prophylaxis if the platelet count permit, like aspirin or the low molecular prophylaxis. But the guidelines, actually European guidelines, do not routinely recommend thromboprophylaxis for lenalidomide in MDS.
And that's very kind. And any experience with oral azacitidine off trial? So obviously in trials it's being used, but have you used off trial?
Yeah, I know. This is something that I have been so much looking forward to, but I still haven't got my hands on that. And we go through very stringent funding process, so it's still awaited.
That's very, thank you, Dr. Mang. Now I've got a question to Dr. Usman Sheikh. Dr. Usman Sheikh. So again, a very, very exciting talk, and thank you for sharing your experience as well in the context of hemophagocytic lymphohistiocytosis. So how in secondary HLH, how you differentiate between that which patient you're going to be using only steroids and which patient you're going to be using full HLH 2004 protocol?
Okay. Most of these patients actually responded very well to dexamethasone, high dose steroids, and which show improvement from both clinical as well as from laboratory perspective. However, it is important to note, even in pediatric age group or even in adult, we have to rule out underlying mutation, because in 40 to 80% of pediatric age group revealed some sort of mutation as compared to 15 to 20% in adult patient. So it is quite possible there's a trigger, these autoimmune disorders or viral infection or lymphoproliferative disorder, which are the three most important underlying etiological factor in HLH, secondary HLH. So we have to rule out underlying mutation in these patients. So once if someone found this mutation, then we have to treat according to HLH 1994 protocol or 2004 protocol.
Thank you. And that just leads to another question which has come in our mind as well, that if we've got a secondary HLH in the context of hematological cancers, which is not a very uncommon scenario where we are working here at Shaukat Khanum, how do you work around the context of treatment of HLH versus chemotherapy, or use steroids plus chemotherapy, as you mentioned in your presentation as well?
Okay. Ideally, one should target the disease first. Say, for example, if there is underlying lymphoma, as it is most commonly associated with lymphoma, you need to offer treatment as soon as possible of underlying lymphoma and then look for the overall response. So steroid is a pack and parcel of all type of lymphoma. in the it is one of the integral component in all type of lymphoid disorder. So that depend on the response. And sometimes if the response is not or suboptimal, then you consider for transplant.
Thank you, Dr. Usman Sheikh. So I've got another question to Dr. Kamran Rashid. So Dr. Kamran, you nicely talked about different trials and different outcomes, and you've talked about maintenance with brentuximab post-autograft as well. So as you know, brentuximab is still quite expensive in our part of the world. And so in Shaukat Khanum, it is not being funded. So obviously we can't offer it to most of our patients except private patients. So your experience in the context of private setup, how you kind of, do you offer them routinely, or how does it work? Because by then the patient had an autograft, they have already spent a lot of money, they have already spent a lot of expenditure.
Well, in the study, the Athera study, there and future studies also, you need to have 5 risk factors before you qualify. And if you have more than 2 risk factors, then you qualify for brentuximab vedotin maintenance, or maybe pembro maintenance or nivolumab maintenance. Now, those 5 risk factors are that you need to have either it's a primary refractory or less than 12 months, right? This was all Athera inclusion criteria. Or you have at the time of relapse, you have B symptoms, right? You have extranodal disease, you have taken more than 2 therapies, or you are in PR or stable disease at the time of relapse. So if you have more than 2 risk factors, these are the ones who really benefited from maintenance brentuximab vedotin. And if you have more than 3 risk factors, their hazard ratio went down from 0.4 to 0.3. So I believe more the risk factors, I believe more concern I will have for that patient, even if that patient had a transplant, that this patient will relapse. Though, you should remember that Athera did not show overall survival advantage. All it showed was the PFS advantage.
Yeah.
So, and the newer studies are comparing brentuximab vedotin with pembro, and pembro is superior to brentuximab vedotin. So maybe in future there are studies going on in which they're using maintenance pembro with brentuximab vedotin, or they're using single agent pembro. There's one study, phase 2, published in Blood, which had shown PFS of 80%, which was the target of that study, and they're doing a phase 3 study. So maybe the future holds more promising for IO. But if patient has more than 2 risk factors, I offer them. I talk to them about brentuximab vedotin. I know it's very expensive. It's very difficult to patient have burned a lot of money to get into the transplant. And most probably in transplant also, they have before transplant they have received brentuximab vedotin in 2 to 3 doses. So it's very challenging. It's very challenging. Actually, we have one patient now who's getting transplant, and we are offering that he's primary refractory, B symptoms, bulky disease. He's a young kid, so we have told them that after transplant, we are suggesting you brentuximab vedotin for a total of 16 doses. 3 he got before transplant. Most probably, I'll offer him 12, 13 doses more after transplant if they can afford. They said they're interested because he's a young kid. They want to do everything for him.
True. Thank you. And I think one of the participants has asked about your personal choice in the context of early stage Hodgkin's lymphoma treatment. I think the question is about chemotherapy therapy alone versus chemotherapy plus radiotherapy. So in stage 1, stage 2,
if you're talking about
favorable.
Stage 1 to favorable,
yeah,
unfavorable,
favorable.
So,
yeah, this is a question from one of the participants. Yeah.
So HD10 very clearly showed that if you are favorable stage 1, stage 2, if you get 2 cycles of ABVD plus INRT, their PFS was 11% better than the arm getting 2 more cycles of ABVD. So I believe HD10 there are other studies, rapid trial and other HD8 trial has shown that there is no role of radiation therapy if you are PET negative. But HD10 trial showed that if you are PET negative, interim PET is negative in early stage, favorable risk Hodgkin's, you are better off getting INRT. And this is what the Alliance trials are using. This will become most probably the standard of care in the future trials. So
you are using combination of
chemoradiotherapy. Yes, I will suggest one more cycle of ABVD
with INRT. So 3 cycles of ABVD with INRT in favorable risk. Whereas in the unfavorable, INRT did not show the benefit. Though the overall survival is the same, overall survival was not different. It was just the PFS which was better in the favorable stage 1, stage 2.
Yeah, I think in that study, the numbers were not powered enough. So that study does show did not any superiority to radiotherapy. But I think in the discussion, they did mention that the numbers are still not powered enough to conclude it conclusively. But it does show the trend certainly that radiotherapy can be taken off, or we can get away with not giving radiotherapy in those kind of patients.
Can I ask one question, Dr. Su? For MDS patients that are transfusion dependent, or the young and they will be transfusion dependent, do you routinely use iron chelation and do you check ferritin, or is it individual based approach? Some people use it and others don't.
Okay, so that's a very good question, and that's still debatable. And for younger patients, which when they become increasingly transfusion dependent, I would consider referring him for transplant. For that, I would like to reduce the iron burden, serum ferritin levels down as much as possible, and I would consider using the iron chelation. The real life uptake of iron chelation is still disappointingly low in clinical practice because they don't tolerate it well. And we're looking at more of the elderly patients with underlying renal impairment or, cardiac dysfunction, or most importantly, most of my patients are slightly deaf and, and that they don't pass the audiometry test. So for older patients, very difficult. In my practice, my uptake has been very, very poor. Younger patients definitely will.
Okay, thank you.
So I've got one last question, again from the participants, Dr. Mong. And I think the question is about that how lenalidomide helps in improving the or decreasing the RBC transfusion in MDS patients. I think the question is about that how they can improve lenalidomide improves the hemoglobin.
Okay, so what we know is lenalidomide improves the sensitivity of MDS erythroid cells to the endogenous or exogenous erythropoietin. The second hypothesis is that it blocks the G2 cell cycle arrest and it interferes with the apoptosis of the cell. There are so many other theories available, but I'm afraid this is what we know. But I think I would dwell on improving sensitivity of the MDS and erythroid cells to erythropoietin.
I think that's very kind, Dr. Mong, Dr. Kamran Rashid, and Dr. Usman Sheikh, and Dr. Farooq Hashmi as well. Thanks for excellent talks, and hopefully we'll be having some more exciting webinars and symposiums in future as well together. Thank you.